So the next panel, I'd like to invite my colleague James Swan from Bloomberg B&A to come up with his panel on the future of Medicare Advantage. Please join me in welcome.
It'll certainly be a hard act to follow, but we'll do our best. And we're going to try to make some sense of a Medicare Advantage and look to the future of the Medicare Advantage program, especially in the larger context of possible overall changes to Medicare. So let me just introduce our distinguished panel. First of all, we have to my right Patricia Newman, the Senior Vice President, Director of Program on Medicare Policy and Director of Medicare's Future Project at the Kaiser Family Foundation. And we have Stacey Sanders, Federal Policy Director at the Medicare Rights Center. And at the end of our panel, we have John Blum, Executive Vice President of Medical Affairs at Care First Blue Cross Blue Shield. And what I'd like to do, we're going to all have a nice conversation here. We want to keep it as open, as live as possible. But our panelists are each going to speak for about 5 minutes each. And then we're going to open things up, and hopefully we'll get a lot of audience interaction and a lot of good discussion. So we'll start with you, Patricia.
Thank you. Thank you, everybody. Thank you, Congresswoman Schwartz, for having us here, and the folks at Bloomberg. Can you not hear me?
We can when you talk towards your mic.
Okay. I'm not sure I have that much to say, but the task really is we're here to talk about is what might happen in Medicare under a Trump administration. And boy, is that a hard task. I think none of us feel particularly competent to project the future, but I thought I would lay out 5 options that we can all think about and talk about. But I do think it's fair to say that these are options. I have no idea, and my guess is the policy environment is evolving rapidly. So take whatever I say with a grain of salt, because I think it's a moving story. So option 1, looking at what was proposed by candidate Trump, was repeal of the ACA. And while people think about that as the coverage expansions and the insurance reforms, the ACA included major changes to Medicare. And so the question is, what happens to those changes in Medicare? Medicare Advantage payment cuts and reforms were included in the ACA. I think it's generally thought that they're not going to go away. If so, it would have big budget implications. But there are other changes to Medicare that were included: benefits, IPAB, which probably doesn't have a long life, the Center for Medicare and Medicaid Innovations, which is doing interesting things with respect to quality and savings, but is also controversial. I would have said, based on the pre-election discussion, that would be a big issue for Medicare, and that I'm putting as option 1. Option 2, I would say include that plus tweaks in Medicare payment policy. That, this could happen within the administration. It could be something that Congress does, but Medicare is a big program. It has a lot of providers and plans that rely on it, and of course 57 million beneficiaries who rely on it. So one could imagine tweaks. One can also imagine savings once we knew whether Medicare savings are on the horizon, right? Medicare is 15% of the federal budget. So if this next Congress administration want to do something about budget issues, in some fashion, Medicare would be on the table. So option 3 is all of the above, plus what candidate Trump talked about, which is a Medicaid block grant. And we don't think of a Medicaid block grant as a Medicare issue necessarily, or a Medicare Advantage issue, but a Medicaid block grant would affect 10 million people on Medicare, the lowest income people on Medicare, older people, people with disabilities who are dually eligible for Medicare and Medicaid. They rely on Medicaid to wrap around Medicare. They make Medicare work. Medicaid makes Medicare feasible for very low income people. So a question is, if there is to be a block grant, what would it mean for the lowest and sickest and most expensive people on Medicare? So option 4 comes into play once we go from the sort of pre-election to post-election environment. And when we look on greatagain.gov, which is the sort of most current version of the policy positions of the Trump administration, we see the term Medicare modernization, which is not something that was talked about during the presidential campaign. And the question is, what does that mean? We have to fill in the blanks a little bit on that one, and more importantly, the administration needs to fill in the blanks on that one. In the past, Medicare modernization has been a broad term. It was used for the Medicare drug benefit back in 2003, but it's also used to talk about pretty big changes in Medicare, premium support, raising the age of eligibility, cost-sharing changes, other major, what's considered structural reforms to Medicare. We don't know, we can only kind of guess and wait, but now that we see that the word Medicare modernization is on the plate, it will be important to fill in the details. And sort of the biggest option that Congressman Ryan has talked about is premium support, which is called different things. Some people call it voucher, some people call it premium support. More recently, people are talking about it as an expansion of Medicare Advantage. But I guess the point I would make here is, so far, nobody has laid out the very specific details that really matter a lot for understanding what it might mean. So Mark Miller talked about, well, how does the government contribution get set? How will it vary by one area to another? What are the protections for low-income beneficiaries? These are sort of basic questions. Will the government contribution be capped over time or not? Will there be one Medicare Advantage program for seniors today and a separate program for people under 55 if the program is phased in? These are really big questions. So that's something we don't know, and that's something we can wait and see. So then option 5 that could be on the table are the other reforms, raising the age of eligibility, benefit changes like a single Part A and B deductible, an out-of-pocket limit. Some people have talked about that reform as a way to expand coverage. One could see how this could be used as a vehicle to achieve savings. So that is something to keep in mind. So a few final observations, so my knowledgeable panel or co-panelists can tell you what's really going to happen. I think the role of Medicare in the coming years could depend on budget priorities. As I said before, Medicare is 15% of the budget, so if budget issues start to become more of a concern, if there's interest in tax cuts that need to be paid for, often Medicare is on the agenda. We'll have to see. The timing is pretty unclear for a Medicare agenda. Some things are easier to do quickly than others. And so we'll have to see how ambitious a new administration and Congress feels it can be. It may be that some of the bigger changes take time or not. We really don't know. So I think one thing that we do know is that the new administration has a lot on its plate when it comes to health care and health reform, and with a lot of people who depend on this program, including people who are older and low income and many people who are sick. These changes will be important, and we're all going to be watching to see how it plays out.
Great. Well, thank you. And I also want to thank Congresswoman Schwartz and Bloomberg for having me today. And it's a real honor to be on a panel with Tricia and with John. The Medicare Rights Center, if you're not familiar with our organization, we're a national nonprofit organization, and we provide direct services and education to nearly 3 million Medicare beneficiaries and their families every year. And we take that experience and translate it into a policy agenda. And it is through that lens that we evaluate policy making, both administrative and legislative. And so we will continue to use that lens going into this very uncertain time. I think, as Tricia said, we'll very carefully be watching what happens with the Affordable Care Act because Medicare is woven throughout that legislation. And Medicare is affected in many different ways. So a few things that we'll be paying close attention to is the donut hole and the potential for reopening the donut hole. Many of the Medicare Advantage changes, which not only included changes to payment, but also included some really critical consumer protections around a medical loss ratio, around prohibiting increases in cost sharing or paying in Medicare Advantage cost sharing over and above for services like renal dialysis, chemotherapy, and so forth. We'll be watching the Centers for Medicare and Medicaid Innovation. You know, from our perspective, a lot of the innovations that are happening there, both in Medicare Advantage and traditional Medicare, there's a lot of opportunity to improve care and the experience of having Medicare through those demonstrations programs. And so we'll hope that CMMI survives. In addition, we're strong supporters of the Medicare Medicaid Coordination Office, which really does sit at the intersection of Medicare and Medicaid, and has been looking for ways to ensure that those beneficiaries don't fall through the cracks and that they truly can fully access all of the benefits and services that are available to them. And many other things. There are many implications for Medicare tied to the Affordable Care Act. And similarly, I think we'll be looking to see what does Medicare modernization mean, and are we looking at premium support proposals? Traditionally, in looking at the past proposals, we've had a lot of concern about what the impact would be on beneficiaries, and particularly any increases in costs for many people who have Medicare. That's important because by and large, the Medicare population is a low-income population. Half of all people with Medicare live on annual incomes of $24,000 a year. And that's a fact that we have to continuously share with policymakers, both on Capitol Hill and within the administration. I think it's not a well-known fact. And we'll also, again, be looking at all of the potential implications for Medicaid, because there are about 9 million people who have both Medicare and Medicaid. So there's certainly a lot to watch, and I think we expect that those will be highly politicized and highly controversial conversations, but we'll keep coming back to what is best for people with Medicare and what are the impact of these proposals on people with Medicare. And I really can't agree with Tricia enough that the details will matter so much in terms of whether or not these proposals ultimately are a value add for the people who rely on the program today, as well as those who expect to rely on Medicare in the future. I think while there's a lot of uncertainty right now, there's also a lot that remains the same. So before the election, the most common reason that people reached out to the Medicare Rights Center had to do with affordability and challenges that they face in affording their premiums and their cost sharing, with denials of coverage and trying to navigate the Medicare program and the appeals process when their Medicare Advantage plan or their Part D plan most often has denied a service that their provider believes they need. And then lastly, enrollment, and that includes just the basic enrollment of coming into Medicare, as well as a lot of the issues associated with how do I pick the coverage that's best for me? Do I choose a Medicare Advantage plan, which has many important benefits in case management, potentially dental, vision, and other supplemental benefits? Or do I choose traditional Medicare, which has an open provider network, potentially with a Medigap supplemental plan and a Part D plan? And people really struggle to navigate the complexity of this system and all of the options that are available to them. And I think that those will continue to be issues even after the election. So while I think we expect to weigh in on a lot of the bigger picture conversations that are certainly going to happen about the future of the program, we're really hopeful that we can continue to pursue policies that really boil down to the mechanics of Medicare and whether or not we've set up a system that people can be successful in. And I think we continue to believe that there are a lot of areas of Medicare policy that are largely overlooked, that can be nonpartisan, bipartisan, non-controversial, that really just have everything to do with making sure that people are well supported to navigate this program. And I think that will become increasingly important, particularly because I don't think we expect that any of the conversations about Medicare's future are really going to be about making the program less complex. If anything, we are committed in Washington to adding many, many layers of complexity to this program, and we just can't forget that we have to support people with Medicare and their families in navigating that system and really maximizing the program that they've paid into for all of their working lives.
Well, thank you for the opportunity, and thank you to Bloomberg for the chance to speak. I want to make just two basic points that I think are probably obvious to this audience. But the first point is that beyond what Congress may do to the Medicare program, that CMS has incredible discretion and incredible tools to calibrate the Medicare program. And the rulemaking processes, how Medicare sets the quality framework, the quality measures, the payment incentives, will determine the future to many of these pieces to the Medicare program. How should the MA program, Medicare Advantage, grow during the next year? And while Congress will consider macro changes to the law, these micro changes matter. And the other thing about CMS is that it cranks. It has to put out rules by law. And there's not time to deliberate, there's not time to consider, there's not time. These rules for hospital payments, Medicare Advantage payments, Part D plan payments, they have to get out by statute. And CMS staff today, I'm sure, is already thinking about the payment options, the policy options, for how to set the inpatient payment rules for fiscal year 2018, how to set the payment parameters for the MA plans, how to set risk adjustment, how to set coding intensity policies. These things matter. And when the new team comes into HHS, to CMS, they will have to start making decisions very quickly on day one, how to think about risk adjustment for the MA program, how to think about coding intensity policies, what should be the inpatient PPS payment update be. They aren't decisions that can wait for new teams to be confirmed, to go into place. They are day one decisions. And that will set the tone, I think, for how the program will run during the next several years, while Congress may consider big macro changes to the program that Tricia talked about. And back in 2007, 2008, when I served on the transition team, there was a well-articulated debate between the Democratic candidate, Republican candidate for the future to Medicare. One policy that was a huge platform for the current president when he campaigned back in 2008 was how to calibrate the payments for the MA program. He argued they should be brought down to fee-for-service. And so when I came into CMS, back in 2009, there was a policy framework that I could point to say the person that I work for, wants the program to be shaped in this general way. I think the challenge for the next team coming in is that Medicare wasn't part of the national conversation. There isn't a well framed out future for the Medicare program that was part of the campaign platform, Republican or Democrat. So the next team coming in, the Secretary, the CMS policy leadership, they will determine very quickly very important day one decisions that will determine the future of the Medicare program. The CMS team can calibrate through their authorities that Congress has granted CMS how to grow the MA program or how to shrink it. They can calibrate what the margin should be for various providers. They can calibrate how to set Part D formularies that will have tremendous impact to how Medicare beneficiaries receive their Part D benefits. No one here in the room knows what these policies will be, but would urge the next team coming into CMS, these are day one decisions. When you come into CMS on January 22nd or 23rd, the staff has already framed the options. You will have to decide very quickly. And that will set the tone, and that will set the calibration going forward beyond just what's the age for Medicare, what's the premium support policies being considered. These day one decisions matter and will set the tone for the next couple of years. The other point that I will make, which really hit home to me when I left CMS, is that despite the national conversation about having one Medicare program, throughout the country. That's the policy principle behind the Medicare system. We have one premium for fee-for-service. We have one benefit design. The reality is that we don't have one Medicare program. We have many, 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 many Medicare programs, and Mark talked about this. And so when I left CMS back in May 2014, my mom, who was a teacher her whole life, retired, and she joined the Medicare program. She lives in the Chicago area, and went through the due diligence with her of checking the Medicare Compare and looking at fee-for-service versus the MA program and the Part D program. And no offense to my plan colleagues working in the Chicago area, but the MA options in the Chicago area are kind of lousy. Premiums are high, there's no provider network to speak of, and her best choice was to go into the fee-for-service program, purchase supplemental coverage, and purchase private Part D coverage. My dad, my parents are divorced. If you were to draw a straight line from the Chicago area across Lake Michigan, about 30 miles across, you would hit my dad's house. And he's in Michigan, about 30 miles away on a map and about an hour and a half drive around the corner, still part of the Chicago metropolitan area. And his plan choices are phenomenal. Great provider network, choice to just about anybody, low premium, great Part D coverage. And just that dichotomy will be the reality that the next leadership team faces, thinking about how to calibrate premium support, how to calibrate fee-for-service benefit, how to think about ACOs. They will face the pressure from Congress, from the public, to have much more equity across the country. But the reality is we don't have that equity. And just take my mom's example, my dad's example, 30 miles apart, about an hour and a half drive around Lake Michigan, but a phenomenally different choice architecture. And that's going to be, I think, the challenge that Congress faces, that CMS faces, the next secretary faces, when he or she is thinking about the future of the Medicare program. They will have to grapple with the tremendous geographic disparity in payment levels, benefit levels, choices, provider networks that the country faces. And that's going to be, I think, the greatest challenge, thinking through the options that Tricia and Stacey talked about. So I'll stop there.
Well, that was very, very great. I'd like to kick off the conversation, and we'll open up to the audience in a second, but I was hoping to drill down a little bit into Medicare Advantage, and just, I know we can't really make any speculations about what the incoming administration is going to do regarding policy, but I was hoping we could have a discussion about some of the challenges or opportunities facing Medicare Advantage, not getting into necessarily the incoming administration, but just what that program faces in the coming years.
Sure, I'll start. I think the program today is in a much stronger position than maybe it was 10 years ago on a number of fronts. It's much broader public support than there was 10 years ago. And I think the growth, particularly in certain geographic areas, has built a tremendous constituency for the program. And so there really is no option to consider Medicare changes in the future without having the MA plans being front and center. The quality framework that went into place through the ACA has transformed, I think, the conversation that plans have with their members, with the government, about how to build a better experience. The CMS team, during my time, put in place a much more stringent oversight framework to ensure that plans are providing the benefits that they've contracted for. I think the program today is in a much stronger position. I think the questions for the future is how to think about the quality framework going forward. Most of the plans today have achieved 4-star and 5-star status. Does that trend, does the next policy team want that trend to continue, or do you want more of a bell curve type quality result where you have half the plans higher than average, half the plans below average? I don't know. How to think about risk adjustment in the future. The system rewards those entities that can code and document their patients more accurately. And I think a fundamental question you have to think about when having the plans compete head-to-head to fee-for-service is the plans will always code their patients better than fee-for-service can because they have physicians that are working more actively. It's not a bad thing, it's just reality. So those are the questions I think for the next team, is how to think about the quality framework, how to think about risk adjustment, how to think about making sure that beneficiaries have more more parity in benefits, network access. Thinking about my mom's example versus my dad's example, those are the questions for the future.
Yeah, I would agree with a lot of that and say that, we certainly think that Medicare Advantage has improved over time, and I think the quality ratings and the STAR metrics have been a big part of that movement. And we certainly find that there are beneficiaries for whom Medicare Advantage is a great option, and encourage them to choose that and evaluate Medicare Advantage next to the options that they have in traditional Medicare. I think one challenge in Medicare Advantage is that you see a lot of proposals to provide enhanced flexibility to Medicare Advantage plans, either through supplemental benefits or changes in benefit design to ensure that they can serve particularly people with multiple chronic conditions. And I think there's a lot of value in those initiatives and the potential that they have to provide better care to those individuals. On the flip side, and as I had said before, they add additional layers of complexity to an already very complex program. So people, when they're choosing Medicare Advantage, have to evaluate their premium, they have to evaluate cost sharing, they have to evaluate provider network, they have to evaluate potential restrictions on their coverage, they have to evaluate what supplemental benefits are available. And I think that as we think about making Medicare Advantage more personalized and more attuned to the needs of people with chronic conditions, we do have to recognize that we are making the program more complex. And so again, are we supporting people in fully evaluating their options and understanding what they're signing up for, and then understanding in the next enrollment period, is this still the right option for me, or is there something else out there? And are we appropriately encouraging people to make those annual evaluations of their coverage? I think from the Medicare Rights Center perspective, we're not doing enough in that space. I don't think that conversation has really kept pace with the conversation about how to help Medicare Advantage plans do more, particularly on behalf of those people with chronic conditions.
Just a couple. Can you hear me? Just a couple of points to add. I think networks is something that will get more attention as an issue, and probably should. There's a great deal of variation. We know very little about Medicare Advantage networks. We know they vary in terms of hospitals. We actually know nothing about physicians and specialists, and I think that's something that might be of interest to consumers, and they may be paying more attention to. I think a big question is how are plans serving high-need, high-cost populations, and what can we learn about that? The quality measures are as good as they can be, but they tend to tell us things about things that are easy to measure, because CMS is balancing the not wanting to put too much of a burden on plans, and you can't measure what you don't know how to measure. But the biggest challenge in our healthcare system is managing costs and care for high-need, high-cost patients. And so just as that's an issue for traditional Medicare, it's an issue for Medicare Advantage as well. And then on the last point of consumer engagement, and this is something that Leslie raised in the context of Part D, we know that people don't really switch. They sign up they choose between Medicare Advantage and traditional Medicare when they first go on the program, and they tend to stay with their plan. They tend to stay with traditional Medicare. And once they choose Medicare Advantage, 10% change every year. And that might mean they're really happy, and it might mean their plan is great. But their needs change, their plans change, networks change, and if people aren't changing, it speaks to the assumptions both behind Medicare Advantage and behind premium support, because the idea is that consumers will evaluate their options and make the best choice for them. In the case of premium support, the hope is that they move to lower cost plans, because that lowers their costs and lowers Medicare costs. But if people aren't moving, then things might not work according to the plan.
I'd like to just build on what you just said with premium support, just to have one more question for the panel before we open to the audience, and that's just how premium support, which has been a strong point for the Republicans, how that would impact Medicare Advantage, if anyone has any kind of idea of what that would mean. I know we're into the realm of speculation, but if anyone wants to take a...
So to Mark's point and to Tricia's point, the details matter, and I think premium support means different things to different people. But I think the concept conceptually works best in areas that you have a lot of competition with private plans and where there is really robust competition between the plans and traditional fee-for-service. The parts of the country that can really support that degree of competition tend to be South Florida, Pittsburgh, the Pacific Northwest. And the political differences are very interesting to me. And I think they shifted during my time in government, that traditionally Republicans tended to like the private side of Medicare, and Democrats traditionally tended to like fee-for-service more than MA, but that shifted over time as the plans became much more concentrated in large urban areas that tend to be much more democratic. So the parts of the country that are generally conceptually more conducive to having competition where plans can really submit competitive bids relative to fee-for-service, in South Florida and Pittsburgh and Seattle, Los Angeles. Those are, I guess, mostly blue areas of the country. And I think that's going to create, I think, geographic tensions, political tensions, that generally Republicans, it's not a partisan statement, I think it's true, tend to support premium support more than Democrats do. But the parts of the country that can support those models more than other parts tend to be more, urban areas, democratic areas, and I think that's going to be sort of the tension. And so what always happens when these debates happen is, it happened during the Part D debate, where Congress considered very targeted demonstrations of premium support, never implemented, because those geographic areas that could best be supported said, don't do this in my backyard because we don't want fee-for-service premiums to go up. And so I think that's the fundamental question, going back to the point that Mark said and that I was trying to say, is that these geographic differences matter. And there really isn't one Medicare program. Certain parts of the country can conceptually support these models than others. In Maryland, we don't have any MA plans to speak of, save for a couple provider systems. We're not going to have premium support here in Maryland. And so that's the fundamental tension. And you really drill down to where you can think about private plan competition. Those are largely democratic areas. And I have to believe that those members of Congress, those senators, will be very resistant to having their part of the country be the first wave of new Medicare models that could have tremendously significant impacts to how benefits are delivered.
I'm okay.
Well, the only thing I think I'm just amplifying, I'm not really adding, is the geographic differences. So depending on how the government contribution is set in a place like Miami, where traditional Medicare is a lot more expensive to run on a per capita basis than Medicare Advantage plans, people who want to stay in traditional Medicare will pay more. Their premiums will go up a lot. But in low-cost areas like Seattle, as Mark mentioned, or Portland, where Medicare costs are low, and you can imagine that the weighted average would be relatively low, people would have to pay considerably more in premiums to keep their Medicare Advantage plan. So this is a hard thing to titrate across the country so that people can keep the plan that they prefer, or policymakers will be willing to accept the fact that in Miami, people will just have to pay a lot more for traditional Medicare, and in Portland, they'll just have to pay a lot more for their private plan. They may or may not be willing to swallow that.
Well, it looks like we have a few minutes left. If anyone in the audience has questions, we've got mics around. Any?
Hi, Tara Hayes with the American Action Forum. All three of you spoke to two different points that I think are similarly related, and so I have two questions, but I think they go hand in hand. So you spoke one about network adequacy, and I believe it was Ms. Newman, you said that it's very difficult to understand the size of the networks in MA. But my first question is, why is that? Because we seem to know a lot about network size in the exchange markets. That's something that's frequently talked about, that they're very narrow, and we have data on that. So why do we not know what that is, what that looks like in MA? And then secondly, you spoke, all three of you, about how difficult it is, the inertia problem, that people just stay in their plan. It's difficult to shop and understand the complexity, all the different things that impact whether MA or fee-for-service is better for them. And so going along with, we don't know network size, and there's many other things also, right, that are difficult for a beneficiary to know. Do you think that it is worthwhile, or have you looked into research as to how to better inform beneficiaries and help them make better decisions? Are there cues you can help them with, when they're enrolling, red, yellow, green, with the plan, some kind of rating system? I know there's some of that on the Compare website, but are there better things we can do?
So I'll happily take the network question. This is something that CMS really could do. CMS does not post networks for Medicare Advantage plans. So we did a study, and we have some rocket scientists who work in our building, and they did a study on Medicare Advantage plans, and they had to collect the information individually from each plan. They got big directories, they got Excel spreadsheets, they got searchable websites. So PhDs with great degrees had to do a lot of work to try to figure out, and it was hard. CMS could post this information. The other thing that they encountered was a lot of incorrect information. So even for my mom, who might do the research or ask me to do the research, they might get, it's hard to do, and the information is not correct, and CMS could kind of up the ante for plans to make sure that they do their best to keep network information current and accurate. And as to why it's difficult, Stacy may want to talk more about it. We've done focus groups. People just say, it's too hard, there are too many plans. On average, people have a choice of 19 Medicare Advantage plans and more Part D plans. It just takes a lot of work. I'm a huge fan of the Part D Plan Finder for Part D, but I'm kind of geeky that way. I don't mind entering in all the information, but I think for a lot of people on Medicare, remember 30% of people on Medicare have a cognitive problem or a mental problem. It's a lot of work. So yes, can it be done? Can Medicare rights do it all? I don't think so. So people need support.
Yeah.
Go ahead.
Yeah, I guess I'll pick up on some of John's theme about what the role of CMS is related to your question. And in Medicare, I think differently than the exchanges, there are really clear regulations about network adequacy. CMS has announced in previous call letters that they are undertaking initiatives to improve access to information about provider networks. And I know there are also initiatives that several of the health plans and associations are engaging in to try to improve access to information about provider networks. Similarly, CMS through regulation ensured that they kind of consolidated plan choice to ensure that there were meaningful differences among plans to help people have better options to choose from and to try to minimize some of the unnecessary duplication. So there are a lot of policy opportunities through regulation, I think, to improve some of these circumstances. I will say that I would agree wholeheartedly with Tricia. Plan Finder is a great tool for Part D. I think in our experience, it is not a great tool for Medicare Advantage, primarily because it does not include provider network information, which is critical to someone's decision making when they're choosing a Medicare Advantage plan. There absolutely is more we can and should be doing to support people in this decision making. I'd point out that the State Health Insurance Assistance Program, which operates in every state and U.S. territory, Medicare Rights is a part of the TA Center for that plan, for the SHIPs. It has been flat funded year after year after year after year, despite the fact that we have more people coming into an increasingly complex program. And this year, the Senate, in a bipartisan fashion, voted in the Appropriations Committee to zero out funding for the SHIPs. So I think there's a real disconnect between the things we want to achieve in the Medicare program and the extent to which there's a political will to really support people in being successful in that program.
I think one more point to add to that is that being at Care First right now, we are certainly facing tremendous pressure to provide the public, our members, more accurate provider directories, and we're doing our best to respond to that pressure. But it's not just the plan's responsibilities for how to create more accurate provider directories. The fact of the matter is what creates the inaccuracy isn't just that plans don't share the information, but physicians change their locations tremendously, with tremendous frequency. And so as we think about a policy framework that would help members better understand provider networks, who's in, who's out, plans have responsibilities to be sure, CMS has responsibilities to be sure, but so does the provider communities. To notify plans, notify CMS, notify the public monthly sometimes where they're located, where they're practicing, and they change tremendously. So that's one challenge that we as I think a broader community need to solve, not just have CMS, not just have the plans bear the full responsibility.
I think we might have time for one more question. We've got two people. We've got.
Hi, I'm Peggy Ty with Powers Law Firm, and I think all three of your organizations are familiar with the Independence at Home demonstration that's sitting in CMMI. And that's one of the things that with the new political climate, very curious, what is going to happen to CMMI? As Stacey has said, none of us really know that. But do you see room for that kind of innovation going forward? Will you fight for that kind of innovation going forward? What are the features of that kind of program, if you know it well, that you might want to share about how that is different? I would just say that what I think is important about it is it targets the sickest of the sick and the most expensive population under Medicare. We haven't today talked very much about the cost. We've talked generally about the cost, but we haven't talked about the fragility and how very sick those people are at the end of life. Those kind of innovative things, I hope, as you can tell, like to stick around. What is your opinion about that?
In theory, a program like that would have bipartisan support, right? That it's it's targeting interventions exactly where they need to be. I've gone around with some of the docs that do the Independence at Home activities, and when I get to that stage, I hope one of them is around and the program is around for me. Will this get swept up in something bigger? Who knows? I don't know that there's any opposition to Independence at Home. It is sort of a tiny little jewel in CMMI, and it has proven to be quite successful in meeting its savings and quality targets. So I don't think anybody would go for Independence at Home. I don't know beyond that.
Medicare Right Center certainly supports the demonstration and has supported its continuance and expansion. But I think your question raises sort of a bigger question about all of the many bipartisan initiatives that are underway at CMMI and the bipartisan support for payment and delivery system reform and the shift towards value that really started with the Affordable Care Act and then continued through MACRA and the doc fix legislation. And I think that, that there's just a lot of uncertainty right now about how that entire space of policy fits into this broader conversation about repealing the Affordable Care Act. And I'm hopeful, but I think a lot remains to be seen.
So if past is prologue, I think every new political CMS team will go through a complete catalog. What are the current projects in place? What are the demonstrations? What are the contracts? And do their own independent review, whether those are things they want to continue. And I think the natural thinking will be that was the old team's projects. Now it's the new team's time to set their agenda, to set their priorities. And so right now is a critical time to make sure that the projects that are currently in place fit into the new agenda, because once the team does come into place, they will ask for that catalog. They will go through it line by line and say, is this good, this is bad from our vantage point, and that's why the people matter and their priorities matter, and now is the time really to make sure that they understand what the impact has been.
And I guess just one last quick question.
Yeah, so quick question. Rob Huffman, Rhythm Management Group. As I'm listening to everything, I'm wondering, and I'm new to the medical space, so I'm a little ignorant in a lot of these things that you're saying, but what is the driving force behind the disparity between the regions that you're talking about and the plan differences? What causes that? Why are there different regulatory commissions under the MACs, or the MACs under the CMS?
There's far wiser people in this audience that could answer that question better than I. But the Medicare program's foundation was built upon national benefits, local coverage, local benefits. It goes back to the history of the Medicare program, that the compromises that were set, that local policies would determine what's covered, what's paid for, and that created just tremendous differences in how benefits were delivered throughout the country. We have different provider systems here. You know, where I work today, we have 4 major hospital systems that practice very differently than I'm sure the major hospital systems do in the Chicago area where I grew up. These are just local preferences. And as a result, Medicare spending varies widely across the country due to local preferences. And the payment levels get set based upon those histories. And that creates differences, creates different payment levels, different premium levels for the Medicare private plans. And it really is a function of how medical practice works. And there's long history to these payment systems. And when you change the payment systems, you have to deal with those differences. And that's just the reality of the system that's been created. But much wiser people than I can answer that question.
Looks like that's all the time we have, and I'm sure this conversation will continue as we move into next year. I'd like to thank Congresswoman Schwartz and the Better Medicare Alliance and all of our great panelists. So thanks everyone for coming.